Hello and welcome to our today's webinar with the title Beyond What We See, the Clinical Value of Retinal Function Testing. I'm Ulrike Rahn, the Director of Clinical Marketing at LKC, and I am going to guide you through our today's event. Our today's event is very special, and I'm very happy about the fact that we can welcome 3 speakers today. Let me introduce them briefly to you. These are Professor Chen, who is ophthalmologist at the Lions Eye Institute of Perth in Australia. He leads the Ocular Tissue Engineering Laboratory and is acting as head of Centre for Ophthalmology and Visual Science at the University of Western Australia. His work focuses on stem cell treatments for macular degeneration and rare genetic disease. That's a field where the ERG, the functional testing, is an indispensable tool, and he will take the time today and give you an overview, a rehearsal of how ERG is used in that very particular field of ophthalmology. Our second speaker today will be for Professor Smendowski. He is ophthalmologist and researcher at the Medical University of Silesia in Katowice, Poland. And he is acting as head of pediatric ophthalmology and a deputy head of ophthalmology in Katowice, Poland. His work focuses on gene therapies for glaucoma and retinal diseases, and he also leads a lot of innovations in that field. That's why he's now today giving us a short overview on the PhNR in the ophthalmology setting. The third speaker today will be Dr. Hussein. He is the consultant ophthalmologist at the View Hospital in Doha in Qatar. And he specialized in cataract and retinal surgery with advanced vitreoretinal training from various countries in Europe and Middle East. He helped launching the ophthalmology service at the View Hospital in Doha, in Qatar, and he will share a few cases from his very busy retinal clinic from a really routine setting, how to use the functional testing with ERG in that setting. As I already mentioned, each of the speakers has his talk. We start with an introduction. We go over the photopic negative response in the ophthalmology practice, and we end with the routine specialist ERG applications. With that, I would like to hand over to Professor Chen to share his presentation and give us a brief rehearsal about ERG.
Thank you, Ulrike, for the introduction. It's a pleasure to talk to you through today on the basic concept through clinical examples. Okay, here's my conflict of interest. So I'm going to start with a slide listing 3 myths or truth. The first scenario is when you see an abnormal macular OCT scan of a patient with suspected inherited retinal disease and there's no peripheral changes, you must be dealing with a macular dystrophy and not a cone or cone rod dystrophy. Is that myth or truth? The second scenario is when you see a patient with a normal ultraviolet autofluorescence imaging and a normal macular OCT in an asymptomatic patient. You can be reassured that this patient does not have any retinal or macular disease. So a situation like this, somebody who comes in with a cataract, and you think, okay, the retina looks normal on all multimodal imaging, therefore this could be a good candidate for multifocal IOL implants if they want to be spectacle-free. Is it truth or myth? Lastly, only ERG recordings done in a dedicated electrophysiology laboratory in a tertiary center can be useful in clinical assessment. True or myth? So with the first question, I'm going to give you a few examples. These are OCT scans through the macula, and some of them showed very subtle changes in the ellipsoid zone. For example, these, I'm going to use a marker. Don't know if you can see my cursor, but on the left-hand side, there's a gap or optical gap. On the right-hand side, these 3 OCT shows attenuation or abnormality in the ellipsoid zone. And down the bottom right, there's a gap there as well. So are these macular dystrophies? So LA30, or the light adapted 30 Hz flicker, looks something like this. But if you actually see that kind of tracing, you'll be pressing the arrest bell. This is ventricular tachycardia. So ventricular tachycardia, as you know, is a life-threatening condition. Now, we're not dealing with that, but the waveform can be quite similar. So this is what a waveform of like adapted 30 hertz looks like. There's peaks every 30. It's at a rate of 30 hertz based on the stimulation rate. And the parameters that we extract from this are the two things. One is the peak amplitude and the peak time. And there's a range that we look at, see whether that's within the normal range. The LA3, here's Quentin playing the game here. So LA3 consists of A and B wave. This originates from the cone photoreceptors as well as a bit of bipolar cell and the bipolar cells. So from this testing, the single flash or 2 hertz flash, we can tell whether the abnormalities are located in the photoreceptor or post-photoreceptor level. And so there are parameters that we can look at, for example, A wave and B wave amplitude and peak time. So both of these tests are useful in looking at cone pathway abnormalities. The LA30 gives us an indication of whether there's global cone abnormality, and LA3 to localize where the abnormality is, whether it's at the photoreceptor level or post-photoreceptor. So here are the results. First case, basically flat 30 hertz flicker. So here we know there's actually a problem with the cones, even though the abnormality is localized in the fovea. So it's not just the problem here. The normal retinal areas of retina that looks normal is actually abnormal functionally. Similarly, in the second case, all very abnormal cones. However, the first two does not have an S-cone response, whereas the third one has an S-cone response. So the third case affects the median long wavelength cones preferentially. The next few cases have reduced or delayed cone response, but it's not abolished or eradicated. And in the third case, the dark adaptive response was supranormal as well. It's taken from another paper. So I just want to draw your attention to this recently published review article looking at phototransduction proteins. And in that, it shows the phototransduction cascade. And all of these proteins outlined here can be involved in various forms of cone or macular dystrophies. So we know there's opsins that are involved in capturing the light. And at the end of the chain, the channel has to be closed or open based on the concentration of cyclic GMP. And diseases affect these proteins, CNGA3, CNGB3, as well as opsin genes can cause cone abnormality. So the first three examples were achromatopsia for both top and middle. And the last one is glaucoma monochromacy, where the abnormality is in the loss of long and medium wavelength opsin gene. Now, it's important to know that when we see a flat 30 hertz flicker, we need to consider whether there's preserved S-cone. There's a few conditions where S-cone can be preserved despite a flat 30 hertz flicker. And these are the conditions listed here. So in glaucoma monochromacy, we know the short wavelength cones are not affected. GNAT2, that's transducin protein that causes achromatopsia, can also have preserved S-cone. And PDE6C and PDE6H, which are phosphodiesterase proteins, can also have preserved S-cone. So the fact that we can see preserved S-cone can point us towards these genes in a patient with cone abnormality. The other cone abnormalities that we need to know are guanylate cyclase and the GC-actin protein, so GUCY-A1A, GUCY-Y2D, as well as the voltage-gated potassium channel. So these are examples of cone dystrophy. The top one's due to GUCY-A1A, GUCY-1A, and the second one is GUCY-2D. So these are the most common dominant cone dystrophies. And the last, KCNV2, causes cone dystrophy with supranormal rod, ERG, is uncommon. This is a rare recessive condition. Finally, there are also conditions that affect the fovea and does not affect cone function. So we need to keep in mind an optical gap doesn't always equate to achromatopsia or cone dystrophies. It could be ABCA4 or macular dystrophy due to Stargardt's disease. as well as RP1L1, which is occult macular dystrophy. PRPH2 can cause central areolar choroidal dystrophy, in the third example here, which may only have macular dysfunction with a normal cone function. CDHR1 can be very mild. PROM1 also similarly can just affect the macula without significant cone abnormality. And the last example is surprising, but it's becoming more recognized, is that Bardet-Biedl syndrome 1, BBS1, disease can give you an isolated macular dystrophy. We used to think that this is the disease that causes systemic disease, as well as cone rod or rod cone dystrophy, but it's possible that BBS1 variant in homozygous state or compound heterozygous state can give you a pure macular dystrophy. So what happens if the retinal imaging looks normal? But is it? So here is 4 examples I'm going to give you. First is a 30-year-old man who wants clearance to work in the police force. His retina looks pretty good on autofluorescence imaging as well as the OCT. Another patient, 57-year-old geriatrician, who wants to discuss cataract surgery. He's got a bit of myopia, but apart from myopic changes, there isn't really anything significant. Then there's a 55-year-old male lawyer who has unilateral vision loss. He's been complaining about this washed out color vision perception for many years. And lastly, a 52-year-old female who had LASIK 5 years ago, but noticed declining vision in the left eye, just the left eye. You can see some changes in the left eye, but is the right eye normal? So I'm going to introduce the concept of DA 0.01. So this is a dim flash in the dark adaptive state. So after 20 minutes of dark adaptation, only the rod photoreceptors are working, and they then transmit a signal to the on bipolar cells. So we see a signal here from the on bipolar cell. We don't see the A wave, it's too small here. So it's a scotopic 0.01. It's generated by the rods, but the response we see is from the bipolar cell. Next is the DA3. So this is a standard flash, still in the dark adaptive position. So you can see the waveform here of the economy following financial crisis, which looks like DA3. There's an A and there's a B wave. The A wave originated from the rod photoreceptors, whilst the B wave comes from the bipolar cells. And the ratio between the B to A wave should be greater than 1.2. Anything less than that will be reduced. Anything less than 1 will be electronegative. So here we have the 30-year-old man who wants police clearance to work in the police force. He's 6'12" in both eyes. He's got normal-looking OCT. But his ERG is not normal. So you can see the dark adapted DA 0.01. There's a delayed B wave and reduced. And it's electronegative. You see the A wave is good, but the B wave severely reduced. And we use the RETeval in the clinic to confirm these findings. You can see that there is not just the reduced B to A ratio, there's the Bifford profile in the light adapted 30 Hertz flicker. So in fact, the light adapted responses here gave us a diagnosis. Whereas the dark adapted responses tell us this is electronegative, but actually doesn't tell us which type of disease it is. So it's more useful to do the dark light adapted, plus the on and off responses were attenuated. So this condition is incomplete CSMB, just based on our testing in the clinic, which takes about 5 to 10 minutes without dark adaptation. This is a 57-year-old geriatrician who wants to discuss cataract surgery. And the important part of that discussion is actually what lens to put in. He's myopic. You can see here the choroid is very thin. So we did the ERG in the clinic, which took 5 to 10 minutes. And it shows that he's got a broadened A wave in the light adapted single flash response and a sharply rising B wave in the 30 Hertz flicker. So we have not put in through 20 minutes of dark adaptation to get a dark adapted response. This is all light adapted response. And we can see that on the on and off response, he's got loss of the on response, but preservation of the off response. Based on this pattern, we've got a diagnosis for him without putting him through dark adaptation or even waiting 6 months for the testing. So the diagnosis here is that despite normal looking retina, apart from the myopic change, he's got complete CSMB, even though his asymptomatic. But after further questioning, he says he did have difficulty seeing in the dark for many years. This is a lawyer who's 55 with unilateral washed out color. And OCT looks pretty good in both eyes. There's no thinning of the nerve fiber layer, no thinning of the outer nuclear layer. But on dark adapted testing, you can see that it's almost flat in the right. On the left, there's a reduced and delayed B wave. And in both eyes, there's a mild reduction in the A wave, suggesting some photoreceptor abnormality, but more importantly, there's loss of the B wave. So both eyes have reduced B to A ratio, and in the right particularly, it's electronegative. This is despite healthy looking retina. So his symptom is only in the left eye. However, the electrophysiological abnormalities in both eyes. Lastly, this case had LASIK 5 years ago, ended up losing vision in the left eye following LASIK. So here we can see in the dark adaptive response that there is severe attenuation of the B wave. However, if you look closely in the right eye, which she's asymptomatic in fact, she may even be having, needing surgery soon for her cataract. The right eye, in fact, has reduced A wave. Now, you wouldn't have, you never guessed that looking at the OCT or the autofluorescence that she's got a reduced A wave. So there is photoreceptor abnormality, rod photoreceptor abnormality. The left eye is severely abnormal. And if you look at the single flash light adaptive response, there's also abnormality in the A wave. So that's the normal looking eye, in fact, abnormal. The left eye is obviously abnormal with almost undetectable 30 Hertz flicker. Now we did her ERG, RETeval, because I want to use this device to monitor her right eye. And I can see that her 30 Hertz flicker amplitude is already reduced in the right eye. It's undetectable in the left. So I can use this quite quickly and easily at every visit, every 6 months or every year, depending on the symptoms, to see whether there's progression in her right eye. Make sure she does not develop the same problem. We presume this is an immunological process affecting both eyes, but asymmetrically and symptomatically only in the left. Now, finally, the last myth is that ERG has to be done in a specialized laboratory to be clinically useful. We have, over the last 10 to 11 weeks, now performed over 130 patients, now probably 150 patients, using the RETeval handheld device. The mean age is 40, age range from 4 to 80. And we have used it on various diagnoses, including rod cone dystrophy, X-linked retinal schisis, cone rod dystrophy, Stargardt disease, macular pattern dystrophy, and drug toxicities and vitamin A deficiencies, as well as posterior uveitis, which I want to give you a couple of examples of. These are 2 patients. The first one, 68 years of age. You can see the birdshot lesions. Retina is slightly thinned. And we like to use RETeval, especially looking at the 30 Hertz flicker and the on and off response to track progression. She's been immunosuppressed. And hopefully, with the successful immunosuppression and long-term treatment, that her peak amplitude here in the right eye is not going to decline any further, and that the B wave amplitude is not going to drop any further. So the on response is not going to be affected. This is in contrast to another patient who's similar age, 68, but has extensive chorioretinal atrophy in the setting of birdshot chorioretinopathy, where she has not been immunosuppressed. And you can see that there's extensive loss of inner retinal layer as well as outer retinal layers with preservation of foveal RPE. In contrast, her ERG, this is the light adapted ERG, shows severe reduction in the A and B wave, but there is still preservation of the 30 Hertz flicker. The on responses are gone. And this is what happens in the birdshot situation where, despite lack of any symptoms, disease has progressed over years. So the take-home message from talk is that a macular dystrophy cannot be diagnosed. You cannot diagnose a macular dystrophy just based on imaging alone. You have to demonstrate that the full field ERG is completely normal in the rod and cone pathway, So unless you have done a full field ERG, you can't call it a macular dystrophy. The second point is that a normal looking retina, even with ultra wide field imaging, with autofluorescence and OCT, it does not exclude a retinopathy. You may even have to perform light adapted testing using a handheld ERG, or even putting them through the full ICEF standard testing with the dark adapted testing if you suspect that there is underlying inherited retinal disease to exclude them. And finally, not all patients has to go through 3 hours of testing for the ERG test to be clinically useful. In some situations, particularly posterior uveitis, selected ERG testing may be useful. For example, in patients with birdshot choroidal retinopathy, where you're immunosuppressing them for many years, you want to know whether that is useful or halting the disease process. You may just want to do the 30 Hertz flicker or the on and off responses. And I'd like to acknowledge funding bodies, especially our collaboration with the IRD Registry, NHMRC Channel 7 Telethon, our registrar, Dr. Harry Honan, who has been doing most of our RETeval ERGs, and our electrophysiology service, Dr. Ina Chalva. Thank you.
Thank you very much, Professor Chen, for this nice talk. I dare to ask one question that had already been shown because it's very particular to one of your patients. You have shown the 52-year female post-LASIK patient, and there was the brief question if there was hypofluorescence in the temporal periphery. Could you very briefly reply to that before we hand over to Professor Smendowski?
So this is in which eye you're noticing, because the left eye definitely has hypoautofluorescence around the vascular arcade and superior inferior. So that eye, we know that there is retinal photoreceptor cell loss. We cannot see that in the right eye, right? So the only abnormality was on the ERG for the right eye.
Thank you for that. Thank you. So with that, I would love to hand over to Professor Smendowski. If you could share your screen.
In the beginning, I would like to thank to LKC for invitation. And this is a real honor to participate in spreading the knowledge about RETeval over the globe. Because I think that this is really breakthrough in the diagnostics of retina, of optic nerve diseases. And after fascinating speech of Professor Chen, I would love to switch to inner part of the retina, and I'm gonna talk about photopic negative responses. Photopic negative responses are new invention actually in the electrophysiological field. However, it's nothing new about the actually recording protocols, because this is belonging to ERG protocol, extended one. And as you know, probably you work with many different various devices for electrophysiology, more or less advanced, older or newer. All of them actually measure the same. They measure the conduction and properties of the retina and visual pathways. Actually PhNR is just another part, another way of measuring this conduction of electrical current in the retina part of the visual pathway. And the PhNR actually focuses on ganglion cell function, ganglion cell conductivity, and it will give information about the action potential that travels through this part of visual pathway. And it is important also to underline that retinal ganglion cells themselves, they are the cells that connect the whole retinal system to the brain, to the centers in the thalamus. And in the past, before the PhNR was introduced, the pattern ERG was used to evaluate this part of the visual pathway. However, now we have the photopic negative responses, which I would try to persuade you are very useful and easier to perform. And actually, when I think about RETeval and all the development of electrophysiology and this technology for the ophthalmic use, you could, compare it to the development of the phones, of the technology of the cellular phones, And actually, RETeval is like last invention that could be compared to the touchscreen intelligent phones. So this is really the high-tech achievement in the last few years. So RETeval enables to perform some very specialized and specific tests, and photopic negative response is one of them. I think it's also important to mention that it also has protocol for diabetic retinopathy screening and also SCON protocol, which are all three quite unique for use in case of RETeval. Photopic negative responses are giving a lot of information. Actually, it would be very much simplification to say that photopic negative responses give only information about ganglion cells activity. It's not true, because I will show you in a moment that there is much more we can obtain from this protocol. And the report or printout is also very specifically constructed. In the printout, of course, you have right and left eye, and you have the pan-photopic responses part, and also the photopic negative responses report. So what is a photopic negative response? Why it's so special? It's a slow negative compound that comes out in the reading in the electroretinograph after the B wave. And of course, it depends, as the name says, on the photopic response. So it's derivative from the whole retinal part of visual pathway. So in this recording, actually, we are obtaining A wave, B wave, and photopic negative response wave. However, these are not A and B wave like in full field flash ERGs, because the adaptation for this test is done with the blue light, and it's done on the blue background, and the stimulation is done with red flashes. So the A wave, actually, because we have light adaptations, are not consisting much of rod's responses, and the cone's responses are also not fully cone responses like in flicker, because we have blue adaptation, which diminish some of the cone responses. And the B wave, which is standard, of course, it comes out from the mostly on-off bipolar cells, some interneurons, and the photopic negative responses, which comes from the ganglion cells. And when the photopic negative response is abnormal, because I will show you there are many different ways to measure photopic negative responses, and we should consider them abnormal if the amplitudes are decreased, which of course is quite logical, but also something that we not often say and not often consider in case of ERGs in general. If the culmination time of this wave is longer than 100 milliseconds, we should already start looking into pathology within the ganglion cells, although the amplitudes might be normal. And there are also two ways of measuring photopic negative responses. They can be measured at the minimum value with no respect to the culmination time, or they can be read at the 72 milliseconds. However, this already, we know that this 72 milliseconds, at this point, the photopic negative responses are not very specific, and they don't really reflect ganglion cells responses only. So in the original printouts, we always had the two values in the past for the photopic negative responses. They were at 72 milliseconds and also at the minimum value. As you can see, the culmination times for the minimum values were not necessary at 72. They could be earlier, they could be later. So actually, after a lot of analysis done, we already know that this minimum volume is more specific for ganglion cell function. However, we need to remember that if the minimum volume is at the latest time than 100 milliseconds, it should be considered already abnormal. So from the readouts with photopic negative responses, you can get 4 different types of combinations of the results. You can get normal panphotopic responses from the retina combined with the normal photopic negative responses. You can have normal retinal function with abnormal photopic responses, photopic negative responses. And also you can have situation in reverse order, that you have abnormal responses from the retina with correct, normal, or abnormal photopic negative responses. And this is particularly very important because if you consider what I said in the beginning, that PhNRs derives or they come out, their continuation of the photopic response of the retina, this is very important to understand that diminishing of panretinal responses might actually affect reliability of the readout of PhNR. And of course, when the technology was created, people who were responsible for describing and creating the device already knew about this, that the photopic responses might affect negative responses as well. So there was an extra coefficient created, which is called W ratio, which is kind of way to normalize the value of photopic negative response and make it less dependent on panphotopic responses from the retina. However, we need to remember that this is only in some sort of way normalizing the value of PhNR. But if really the panphotopic responses are diminished, the W ratio also might not be very reliable. And how we perform this test, this is actually very simple and very fast test, which is done, as I said, with the blue background, red light stimulus. And there are 2 types of making it, S for the ERG itself. So it could be with CD or TD. For the CD, pupil must be dilated. For the TD, so Troland, pupil no need to be dilated because the RETeval device provides real-time pupillography and it adjusts the strength of the blinks to the pupil diameter. And of course, we use the standard sensor strips for RETeval, and we should do at least 2 full tests and average them to get reliable response. So how the strips looks, I think everyone who works with RETeval knows. Maybe not everyone know that there are also small size sensor strips. For example, when we need to test the small babies. However, it's also important to tell that the small size sensor strips, they do not have normative values. If we run tests with the small size sensor strips, we get raw data without normative values. And what is the diagnostic utility of PhNR? Of course, the most, for this it was designed and created, diseases of the innermost retina cells, so ganglion cells, but also we can do the screening test for outer retina condition and the global retinal disorders. And this is something which I personally very frequently use when I have non-cooperative patients. I run PhNR because it's a very fast test. It's not very disturbing to patient because blinks of light are not strong. They are not bright light. And it will give you a screening information about retinal function and ganglion cell function. So this is really, I recommend if you have non-cooperative patients, especially pediatric patients, and they don't let you do much in the office, PhNR recording is very useful for the screening examination on the first visit. In the innermost retinal layers, of course, we mostly want to test glaucoma, but you need to understand and you need to bear in mind that we are measuring ganglion cell function here, and ganglion cells are dying not only due to glaucoma. So in glaucoma aspect, we of course can use it to confirm or exclude glaucoma. For early screening, we can use it also. for checking effectiveness of IOP lowering treatment, and also in pediatric glaucoma for the cases that cannot perform visual fields. It's also very useful. But except this, we can use PhNR test for the genetic optic neuropathies, ischemic ones, any form of optic atrophies, diabetic retinopathy as well. And I want to share with you some cases which maybe will show you how to use in certain settings the PhNR tests. So the first case, glaucoma suspect. This was very doubtful if it's glaucoma in the first contact, but it was recommended to me due to the big optic disc with CD ratio also enlarged. You can see the discs were really huge in this case. However, IOP was normal with thin cornea, so because of the risk of glaucoma development, they sent it for further evaluation. Visual fields, Humphreys, well correct, were fine. And in PhNR also we got the nice correct responses in the right eye -10, left eye -8. So within normal limits. You can see also that pan-retinal responses also within limits. So you can say that the test is reliable and this is non-neuropathy case. Outer layers of the retina can be affected in case of this measurement, in case of this test, by many different conditions. The most common are ischemic disorders, retinal dystrophies, and also vitamin A deficiency. And this we need to remember because we not always consider that we have a huge population of patients with vitamin A deficiency, especially in pediatric patients that do not like eating veggies or they don't have full range rich diet, especially in teenagers or older toddlers which are picky with eating. We always need to consider vitamin A deficiency. And here you have these two situations where you have correct, like normal responses from the retina, entire retina, and diminished ones. So in such cases, you never know if the PhNR is lowered, is reduced because the output from the retina, the generator, is not working properly, or this is real case of the neuropathy. So you always need to combine it with other tests. And the clinical example, you have 20 years old male, 0.6 Snell and visual field, correct IOPs, completely diminished, or maybe not completely, but diminished panretinal responses, and also decreased PhNR responses. And such case always requires checkout with other tests, because of course we need to see how the retina looks, if there is no developmental abnormalities, and how the visual field looks. And this is very beautiful case of X-linked retinoschisis. You can see that the visual fields, of course, they have some scotomas, but of course the retina looks like in OCT attached here. So the retinal responses which were diminished comes from the genetic disease of the retina. So here there is no doubts that the lower responses from the retina are coming from the genetic disease. And another case, this is 6-year-old girl, visual field very low, visual acuity very low, IOP on the border. We know that this child has congenital glaucoma, and it was also suspected to have retinal dystrophy on the top of this. You can see that the panretinal response is very diminished, and also almost diminished PhNRs. And in this case, I would like again to repeat and to remind you, with PhNR, you always need to try to get the photopic responses, panretinal responses, as correct as possible to see if the PhNRs are really diminished, or this is just derivative of the diminished panretinal responses. So in this case, I administer to this child vitamin A supplementation, of course, additional IOP lowering. And you can see after 6 months, the control test, after 6 months of supplementation of vitamin A, you can see that panretinal photopic responses are already much better, which makes the test much more reliable. And the PhNR are, of course, reduced because this is case with congenital glaucoma, but it's already not as reduced as it was before. So in this case, you can use it for follow-up to check the disease progression in this child. And I work with PhNR for some time already. So I did multiple tests. For now, I have, I think, about 1,000 recording for this test in different population of patients. And we did some statistics for our results. And what I can show you that if you have normal panphotopic responses in PhNR test, it correlates very strongly with the pattern standard deviation from the visual fields, RNFL thickness, GCC complex from OCTs. However, when panphotopic retinal responses are abnormal, so they are diminished, the correlation is already almost gone. So this is a major take-home message from me. If you work with PhNR, you always ensure that you have good panphotopic responses, because if you cannot obtain good panphotopic responses, PhNR might not be very reliable to test ganglion cell function. So based on my experience, PhNR strongly correlates with glaucoma functional and morphological factors from perimetry, OCT, especially in absence of retinal function impairment. And weaker or lack of correlation and between the PhNR and other coefficients might limit reliability, and then it might be false test to use to check progression of the glaucoma in certain patients. However, it also might be tricky. Even with the diminished pan-retinal photopic activity, you might get recording of PhNR. So with this, I would like to end my talk, and thank you very much once more.
Thank you very much, Professor Smanowski, for this talk. We will now hand over to Dr. Hussein with his last talk about routine retinal use.
Great, thank you. I mean, I'm amazed by the previous 2 sessions and the information that and also the lessons I've learned from both professors. And here it's, I mean, my journey with RETeval started at, I would say, when I moved to the View Hospital, where we set up a new service, and working back in the UK, where we used to have cover for electroretinography. Moving to a new place, setting up a new service, I was concerned about not being able to refer patients, knowing that they used to have long waiting times until the conventional ERG is done. And for this reason, one of the thoughts were about bringing the portable ERG. And thanks for RETeval for the invitation to take part in this, and also for having incorporated such a service that is helping us on a daily basis. Multiple applications for ERG, as you've seen in the first, 2 presentations, in pediatric conditions, in congenital diseases, in cases where unexplained vision loss is there, vascular disorders of the retina, and optic nerve problems. Anything in medicine is about early assessment, so early detection, so monitoring the progression, also predicting the progression and the treatment follow-up. So this will cover the need of the specialist as well as the need of the patient. Now, in my routine practice, I was thinking about 5 major aspects. Number 1, cases of unexplained vision loss. What shall I say to the patient? cases where my diagnosis needs a bit of refinement, preoperative planning for better prognostic value, especially for diabetics prior to vitrectomies, cataract, dense cataracts in diabetic patients, and also using ERG to plan for to go for a multifocal or a non-multifocal intraocular lens, as Prof. Chin showed us, and also to try to answer the questions when the structure doesn't mean the function. And if you incorporate all that into a medical retina practice or a hybrid practice where you do MR and VR, you can see that there is a huge potential for diabetic retinopathy, diabetic maculopathy, vein occlusion cases, and also the planning for anti-VEGF and PRP therapy, pan-retinal photocoagulation. And when it comes to the diabetic retinopathy, I have seen that RETeval has improved my let's call it the quality of the consultation I'm having with the patient, because it gives me the ability to offer an objective assessment of the retinal function without the need for pupillary dilatation, especially in the presence of wide field fundus photography. It allows me for early detection of the retinal dysfunction that may precede the visible structural changes. I'm able to tell the patient that your function change is preceding the structural, and we need to plan something for you. And the ability to facilitate earlier intervention and also a more tailored treatment plan, and this is vital in those cases. And also the provision of a true physiological measurement of retinal function, as opposed to subjective tests like visual acuity or even visual acuity or other tests. So you're talking about the function, you're talking about something objective, and you're becoming more proactive. I'm not going to go into the RG waveform build, but I think it's an amazing, and I think you will be able to see it as part of the recording. It talks about the A wave, from where it's coming, the B wave, and other waves. But I'll move to the first case. This is a female of 38-year-old. She's got hearing loss since childhood. The parents are likely cousins. She's got 5 brothers, but no noteworthy findings. 2 of the 4 children suffer from hearing problems. Long-standing history of night blindness dating back to childhood. She came for a second opinion. Good, best corrected visual acuity. It's mainly peripheral rather than central, and no prior treatment. This is the wide field fundus photography of her, the color picture, and this is the autofluorescence one, where you can see typical changes. We did the light adapted and the dark adapted cases, and we found that both of them are abnormal. So we've got an abnormal cone function and also an abnormal rod function, as you can see in the ERG highlighted here. And based on those structural, anamnestic, and ERG findings, I suspect Usher. Now, if I were in a practice where I don't have an ERG, most probably this patient would have come to me for a second opinion, and I would have told her, listen, I still have to do an ERG, and I would have possibly trying to reach a conventional ERG center, which would take time. So one benefit in case 1 is that you have early access to something portable, something that you have, and so you can give patients more clue about what's going on. And the next step would be the family screening and the genetic counseling. Now, this is another case where possibly the features of the congenital problem are not that typical. A female, 50-year-old, myopic, complained about vision loss, but she always attributed that vision loss to myopia. And as you can see, the vision in the right eye is 0.9, while in the left eye is 0.5. Unfortunately, this lady had refractive laser in the past for the treatment of myopia, and that was, as per her, to ameliorate the burden of myopia. Now, if you look at the fundus images, you've got those typical changes, but they are circumscribed in the posterior pole. And when we do the OCT scan, we've got cystoid macular edema in the left eye, which is significant compared to the right eye, which is slightly minimal. So as you can see, you've got a case, and this is the ERG. And in the ERG, you've got the photopic and the photopic ERG, which revealed an abnormal cone function, and also the scotopic was abnormal. So in those cases of atypical retinitis pigmentosa, I mean, like, let's go, like if we went back in history into a practice of a refractive suite where they have a portable ERG, this patient should have done an earlier ERG at that time, and this would have saved her the cost and risk of refractive laser. In addition to that, it would have given her much more information about her eye. Go back. This is very important in my practice. I work in an endemic area where diabetic retinopathy is endemic, possibly 1 out of 4, 1 out of 3 of my patients. Now, there is very important talk about the diabetic retinopathy score. And this score is a combination of 3 things. One coming from the pupillary reaction, one coming from the ERG itself, and one coming from the age of the patient. The nice thing about this, it does have a high sensitivity and a high specificity and a low failure rate to detect those patients who are going to progress. And as you can see in this trial, especially if you look at year 2, you can see that in year 2, for example, the risk of progression went above 50% when the ERG was abnormal. But if the ERG is normal, only 4%, as you can see within in the 2-year section, only 4% progress. So it does have a considerable value when it comes to detecting the progression, which means that I can plan treatment accordingly. A male of 46-year-old, proliferative diabetic retinopathy in the left and severe in the right. Unaided vision is 0.8 and 1. The left eye had, as you can see, PRP in the past. The patient was not happy with the experience. He feels that it did not serve him, and he came to me for a second opinion because he was told that he's got changes in both eyes. I did an ERG on him, and I found that the right eye, which is the one that's having inferior ischemia, as you can see here, does have a better ERG compared to the left eye. Better ERG, I mean better what we call a DR scoring. So, and that helped me inform the patient that perhaps we can avoid doing PRP in the right eye, and most probably the ERG changes in the left eye are related to the previous laser. So I tried to go conservatively, help the patient with his treatment plan, and the patient remained treatment-free in the 2-year follow-up. Do not rush for PRP. Look at the function first. The last case is the best case I have ever utilized ERG for. A 72-year-old diabetic, diabetes, dementia, ex-ambassador with single eye patient, vision issues in the left eye, no light perception in the right, best corrected 0.2, has been everywhere. He wanted to see if his cataract can be done. The patient has got dementia, so the family is trying to push, but the family would like to say, when we do the cataract, will his vision improve? And I said, listen, I can't answer this question, but I have a RETeval, and I'm going to use it. And when I did the ERG, I found that the amplitudes and the implicit times were borderline to normal, but were reassuring. So had we did not perform the ERG, I might have possibly told the patient that, it's very difficult to judge. I don't know what's going to happen. But the family with an ERG and myself, we went we went and we did the cataract. The patient vision improved to 0.7. Not only this, his dementia, his signs of dementia have improved because now he's got something that he's relying on, and his interaction with people has improved. Last but not least, an unexpected vision drop after surgery. Patient with diabetes, meningioma, treated with radiation therapy and surgery, prior corneal transplant. So he was offered corneal transplant due to the recurrent herpetic keratitis. The corneal transplant did not improve vision. Now, there was an impression that something wrong was with the optic nerve, but not that significant. So he came to me, nothing improved. I told him could be macular ischemia, optic neuropathy, or radiation induced. We did that, and we found that the W ratio was lower in the left compared to the right, something that's suggesting an optic atrophy, and something that's suggesting a supernormal ERG due to lack of inhibition. So it gave me a clue about the root cause. Finally, as you can see, broad range of pathologies can be detected. I think incorporating this into your practice is vital, and the interpretation requires training. But with time, you will see that it will improve the flow and it will improve the quality of the care that you're offering your patients. Thank you. Thanks, you, RETeval.
Thank you, Dr. Hussein. Also, another thank you to all our speakers. Actually, the 1 hour is now past. I see a few questions. I have a few questions on my list. However, as we are in Middle Europe in the lunch break and Professor Smedowski has some surgery scheduled and Dr. Hussein is at a Congress, Professor Chen probably has other duties as well. So we'll keep it very short to 1 question each speaker. So let's start with Professor Chen. We just go in the sort order of our speakers. There is 1 question that you use quite often, the on-off tests. What would be your main reason or your main trigger to do the on-off test?
That's a good question. The presence of suspected CSMB is the most common reason. If I want to know whether this is a complete or incomplete CSMB, I'll use that test to distinguish the two. There are various types of IRDs where the on response is affected, for example, PRPS2, CRX, where this could be useful, and finally inflammatory eye disease that can affect inner retinal layers or middle retinal layers. I will use that as a way to define disease at beyond the photoreceptor level.
I see. Thank you. Then let's move to the second question that we can still do. Professor Smedowski, we also have the pattern ERG that is said to be part of the ganglion cell function. And what I understood, these 2 tests probably correlate quite well. Do you think that the PhNR can replace the pattern ERG?
Well, I think that both of them give a little bit different range of information. To me, as I mentioned, PhNR gives much more information because it not only reflects the function of the ganglion cells, but also you can use it to like screening of the entire retina. So if it replaces, I think it can work parallelly. However, to my mind and in my experience, I more likely would perform PhNR to get more information about the entire system.
That's very, very good. Thank you. And then 1 last question to Dr. Hussein. In the highly competitive environment of patients that look for a second and third opinion, would you recommend adding the ERG as a routine entry test to ensure further compliance that can be avoided?
It's a bit of a tough one, but I believe absolutely it does have a space. I'm not saying in all, but I believe, as you said, in a competitive environment where patients are coming for a second opinion and are looking for something different from what they have experienced in other practices, I think you need to offer something else, and offering an extra information about the function. I think it's very convincing for the patient, and I think it's very reassuring for the family members. Diabetics, congenital problems, preoperative cataract surgery. I think any glimpse of information you've had in a private practice is vital. And I think RETeval does a good job in handling this sort of peculiar unmet need.
Thank you for this. Then I'm sorry to rush now a little bit at the end. If there are any further questions you'd like to ask in the audience, please feel free to contact us. I have my email address here on the screen. We are also available via our web form. In case there are questions, they will be then directed to us. We are currently at congresses because it feels like the Congress time. We are at Ranske in Australia. We are in Europe at the DOG in Germany and the EPOS in Netherlands. And certainly we have our team at the AAO and in the Middle East area at the SOS meeting. I hope you all enjoyed the webinar as much as I did. I learned a lot today. I still have a number of questions on my list, which I would ask after the webinar. Everyone is getting the recording with some more questions answered. And then I hope to see everyone again. To end the webinar, thank you, Dr. Hussein, Professor Smedowski, and Professor Chen for your time and the very great talks. We'll then keep in touch afterwards. Thank you.